Good afternoon, everybody, and thank you for taking time out of your busy schedules to attend this webinar, which is going to focus today on multi-frequency vestibular testing. There has been a lot of talk in both the literature and at scientific events about how the vestibular assessment has changed and how we can test each vestibular end organ independently. Although this is very important, another aspect of vestibular assessment, which sometimes is neglected, is the fact that we really should be testing the vestibular system at multiple frequencies. Hopefully by the end of today, you'll have a core understanding of the benefits of performing a multi-frequency vestibular assessment. Before we crack on with the main contents of the webinar, it's only fitting that I introduce myself. My name's Lee Martin and I'm an audiologist working for the Introacoustics Academy. At the Introacoustics Academy, we offer training and access to materials related to audiological and vestibular technologies and their applications. If you do need to have an updated knowledge about the caloric test or the video head impulse test, then I recommend that you complete the corresponding e-learning and webinar modules, which can be found on our website, academy.introacoustics.com. When we think about the vestibular system and the way in which we assess it, it's always important to have at the forefront of our minds what exactly the vestibular system is responsible for and how we can measure its function. The vestibular system is responsible for sensing motion of the head to maintain postural control and stability of images on the fovea of the retina during that motion. This statement really brings up two core concepts which are appropriate for today's webinar. The first is that the vestibular system actually talks to different parts of our body. We can see that it helps maintain postural control, such as our muscles and our legs. Also, it talks to our eyes in order to keep our vision stable. The second core piece of information from this statement is that the vestibular system is responsible for sensing motion of the head. So, what type of head movements do we make from day to day? What we can see is that head movements occur over a wide range of different frequencies, from 0 to 20 Hz, and very fast, from velocities up to 550 degrees per second. So we can see that these head movements are very diverse, ranging from very small and very slow to very large and very fast. It only seems fitting that if we're going to assess the vestibular system properly, that we actually test it under these different conditions, rather than just relying on the results from only one type of head motion. Here we can see the anatomy of the vestibular system, and as we know, we have 5 vestibular end organs responsible for detecting linear and angular motion of the head. When we're talking about a multi-frequency approach to vestibular testing, we only have tests which can test multiple frequencies of one of these end organs, and that's the lateral semicircular canal. So how do we actually stimulate the lateral semicircular canal? Well, that's very easy. We can do that by moving our head from left to right, as you can see in the image below. What you can also see in the image below are my eyes. Now this is very important because what the lateral semicircular canal does is that they send projections to the eyes and form something called the vestibulo-ocular reflex. So the vestibulo-ocular reflex tells my eyes to move in an equal and opposite direction to my head in order for my eyes to stay on a target in front of me. So what that means is that when my head moves to the right, my eyes are going to move in an equal and opposite direction. It is looking at these eye movements which is going to tell us how well the lateral semicircular canals are working. And this is the reflex that we're going to be testing with all 3 vestibular tests today. So if we consider the vestibulo-ocular reflex over a range of different frequencies, then what we can see is if we have head movement or frequency along the x-axis and vestibulo-ocular reflex gain on the y-axis, as frequency increases, the vestibulo-ocular reflex gain also increases to a point where VOR movement provides equal and opposite movement of the eyes to the head until we get to around about 10 Hz, where we see the system become less sensitive and tail off. So this tells us that the vestibular system is not very sensitive to picking up very low and very high frequency head movement. But that's okay, because if we look at the range of normal head movements in everyday life, we can see that the bulk of our head movements occur between these two white lines. And actually the vestibulo-ocular reflex is very good at detecting these types of head movement. But having an awareness of what happens at lower frequencies and higher frequencies is particularly important, especially when we discuss some of the tests which we have to measure the vestibulo-ocular reflex. We actually have 3 tests which we can use in order to measure the VOR. The first is the caloric test. In this test, we irrigate the ears with warm and cool water to evoke a vestibular response, which will generate changes in the person's individual vestibulo-ocular reflex. We then compare the responses from the left ear to the right ear, and this tells us the function of the person's semicircular canals and whether or not there's symmetry between these two systems. Another test which we have to measure the VOR is the video head impulse test. This is where we place a goggle over the patient's eyes and we provide rapid rotations of the head whilst asking the patient to maintain focus on a target in front of them whilst we're measuring how well the eye is moving as the head is moving. The last tests which we have are the rotational chair tests, and what these do is we place the patient into the chair and we place a goggle over their eyes, and what we do is we record their eye movements and see how they correspond with the chair movements. And again, we're looking on the large part for an equal and opposite response from the eye movements to the chair movements. So why is it important to have these different tests which are looking at the same vestibular end organ? And of course the concept is we need to test at different frequencies. And an easy analogy to think about is that of the audiogram. Here we can see an audiogram which has thresholds plotted at 500 Hz for the left and the right ear, and we can see that they're within the normal range of 10 dB. If I ask you the question, does this person have normal hearing, then the answer to that question is quite difficult. You can answer that at 500 Hz they have normal hearing, but the test is incomplete. We haven't tested different frequencies of the system. They could have a high frequency hearing loss, or they could have normal hearing in the high frequencies. We just don't know. The same concept happens with the vestibular assessment. If we only test one system at one frequency and the results are normal, this doesn't tell us that the system is actually working normally. It tells us that it's working normally at that frequency. And in fact, if we test at multiple frequencies, then we still might find a deficit. So what frequencies do these tests measure at? Well, if we consider the caloric test, the video head impulse test, and the rotary chair testing, we'll go through each of these separately and discuss those frequencies now. The first we'll talk about is the caloric test. The caloric test is a test of low frequency head movement and corresponds to a frequency of around about 0.004 Hz. A question that I often hear is how have we come to this number that the caloric test measures the system at 0.004 Hz? Well, if we consider a caloric test, we irrigate the ear, and then what we do is we look for a peak response, and then we let the ear cool down. And then what we do is we do the same on the other side. We irrigate the ear, we look for a peak response, and then we wait for it to cool down. When we think about frequency, of course, we're always thinking about cycles per second. And once we have a full caloric response from the left side and the right side using one stimulus, then what we can do is we can create a sine wave. And then what we can say is that frequency is 1 divided by time. So on the graph here we can see that we have one sine wave, and then that each caloric irrigation from start to finish took 120 seconds. So 120 seconds plus 120 seconds equals 240 seconds. If we divide 1 by 240, that provides us with a frequency of 0.004 Hertz. And this, of course, is how we calculate the frequency of the caloric test. And this is why we calculate it to be such a low frequency test. But what about the other tests? Let's now look at the rotational chair test. The rotational chair tests a range of different frequencies from 0.01 Hz all the way to 0.32 Hz. So this provides us with a mid-frequency test of vestibular function. The caloric test was looking at the low frequencies. The rotational chair test can now look at the mid-frequencies. Understanding the frequency of the rotational chair is much more simple. What you can do is you can just measure one cycle of the rotational chair, which we can see in the image here, and we can calculate the frequency by measuring how quickly it takes the chair to do a complete cycle. And then when we look at the vestibular response to this, we can see that we're looking for an equal and opposite response of the vestibular system to the chair rotation. Lastly, we have the video head impulse test. The video head impulse test is a high frequency test of vestibular function. You can see that it's covering the frequency range from 3 to 5 Hz. And this is where the VOR gain is working at its best. Here is a video of a video head impulse test being performed. You can see that the movements of the head are very short and very brisk. And this type of movement covers the range 3 to 5 Hz. And what we're looking to do is to see how the eye moves, and it should move in an equal and opposite movement to that of the head. So what we'll do now is look at some case studies at why we need to test at multiple frequencies. The first case study which I'm going to give you at why a multi-frequency vestibular assessment is necessary is that of a patient which was diagnosed with vestibular neuritis. What we can see is that this patient came to the audiology department 6 months after having their episode of vestibular neuritis. The patient underwent all the standard VNG test battery and of course had a caloric test. What the caloric test showed was that the patient had a normal response, so the low frequency vestibular system was working absolutely fine. Now, if you just relied on the results of the caloric test alone, then you might misdiagnose the patient of not having a neuritis, or they could have had a stroke, or your conclusion to why they have a vestibular problem is inconclusive. However, if we then perform a test at a different frequency, such as the video head impulse test, which was done in this case, what you can see is that on the left-hand side, we are seeing the presence of catch-up saccades which are both overt and covert. The person has a left-sided vestibular pathology, but in fact their vestibular system at low frequencies is not being affected by this pathology, but at the high frequencies with the video head impulse test, then yes, we can see there is a pathological difference being recorded. The important thing to remember with patients with vestibular neuritis is that complete recovery of semicircular canal function occurs in 40 to 60% of patients 6 months after onset. Now this is important because we're going to be seeing these patients in the audiology department often around this time. But what this group found was that actually head impulse testing rarely normalizes. So the system recovers for the low frequency head inputs, but for the fast head inputs, then we still are able to detect the pathology. This is incredibly useful for making a confirmed diagnosis that the patient had a vestibular neuritis. The second case example which I'll present is a patient which had bilateral vestibular loss. Typically, we would use a total slow phase velocity response of less than 22 degrees per second to indicate that there's a bilateral vestibular deficit. But the caloric test is not the most robust test for detecting a bilateral weakness, and it's always recommended to perform some testing at different frequencies. That could be an ice-water caloric, a rotary chair test, or a video head impulse test. So what we can see is that we think there's a bilateral weakness, but we need to confirm that with a secondary test. So what we can do is we can look at the patient's rotary chair data, and what we can see with the patient's rotary chair data, that in fact they're having reduced gain bilaterally on the sinusoidal harmonic acceleration test, suggestive that actually a bilateral lesion is present. But what we also want to see is, are the high frequencies also being affected by this lesion, or is it just affecting the low frequencies? If we do the video head impulse test, then what we can see is actually this patient has a reduced VOR gain with the presence of catch-up saccades bilaterally, which is showing us that in fact this patient has a bilateral weakness which is severe because it's affecting all the frequencies of the VOR. The next case study which we're going to present is somebody which has been diagnosed with Meniere's disease. The problem with testing a Meniere's patient is that their vestibular test results can vary from time to time, especially if they are presenting in a stage of remission or at the very early stages of their disease. This is an example where what we can see is that this patient has undergone a video head impulse test, and what we can see is that they have normal gains and no catch-up saccadic eye movements. Therefore, if you only did one form of vestibular assessment using the video head impulse test, then you might miss the fact that this person has a vestibular deficit. Because if you do a low frequency test, such as the caloric test, we can see that this person is showing a drop in vestibular function, and that's affecting their left ear. But this was not detectable by the video head impulse test. So there has been a group that's looked at this only this year, and they have found that the low frequency and high frequency tests don't necessarily always agree in patients with Meniere's disease, and that patients with Meniere's disease have a small or absent caloric response, but their video head impulse test remains normal. So this tells us that Meniere's disease can affect the low frequencies before it affects the high frequencies, and therefore we need to do a multi-frequency approach to help us identify this. Another reason for performing multi-frequency vestibular testing is measuring compensation status. It's all well and good being able to diagnose a vestibular disorder, but once you've made the diagnosis, it's really important to make sure that we treat it properly. And one of the main treatments for treating a vestibular disorder is vestibular rehabilitation. We can use a multi-frequency approach to measure how well a patient is compensating. So what we can do is use the rotary chair test, and what we can see is that as the VOR gradually corrects for a vestibular insult, the phase abnormality and the asymmetry begin to recover. So we can use the rotary chair test to measure the vestibular response over time. The caloric test is much more difficult, and it's not a very comfortable test to put the patient through. So a rotary chair test gives a lot of information regarding the mid-frequency vestibular response. But what we can do is combine the results of the rotary chair with that of the video head impulse test. And what you can see is that here is an example of a patient which is recovering from a vestibular neuritis. you can see that at the start of their disease process, they have many catch-up saccades which are both overt and covert. But what you notice, these saccades firstly reduce, and then the latency of these saccades begin to group together to show recovery. So what we can see is that using multiple tests, not only for the assessment, but also for the rehabilitation, you can see that if the rehabilitation exercises you're giving the patient are working, and actually if the VOR is improving. If we're not getting an improvement, then this tells us that we perhaps should change our approach and perhaps try something a little bit differently. Keeping on the theme of treatment for vestibular disorders, another common form of treatment is gentamicin therapy, particularly for those with Meniere's disease. What we can see is that in those with gentamicin therapy, often is the case that as soon as you begin treatment, you'll not notice a deficit on the video head impulse test. This is because gentamicin therapy affects the low frequencies first. So if you're only monitoring the gentamicin with a video head impulse test, then you could be missing the parts of the vestibular system where the gentamicin is actually working. If we do a caloric test, what we can see is that this person is actually had gentamicin administered to the right ear, and we can see that there is a caloric weakness. And then you can continue to build up this gentamicin, so it takes out the low frequency response, followed by the mid frequency response, and lastly the high frequency response. This prevents the clinician from providing an overdose and making sure that they fully understand what's happening after each course of the therapy. So low frequency responses with gentamicin are affected earlier and more severely than the high frequency responses. And this is consistent with the damage to type 1 hair cells or irregular firing afferents. The last application I will talk about today with regards to a multi-frequency vestibular approach is that of special populations. And I will give an example of a patient which has a mastoid cavity, but there are many other special populations where a multi-frequency vestibular assessment can be useful. But what we can see is we need to perform a vestibular assessment on this patient. The problem is, as we see, is that there's a mastoid cavity. Now this is going to stop us from performing certain vestibular tests. Most notably, the caloric test. What you'll find is that the caloric test is looking for symmetries between the right and the left side. If there's only a mastoid cavity on one side, then the heat transfer will be different. It's also dangerous to put water into the ear, as that could cause infection, so the caloric test is contraindicated. Therefore, if you only relied on having a caloric test in the vestibular laboratory, then you're not going to be able to make a diagnosis on this patient if they have a pathology affecting the lateral semicircular canal. But what we can see is that if we do a rotary chair test, then actually we can see that this patient does have an irregular phase lead. They have normal gains, but they have an irregular phase lead. Now this can suggest that actually they do have a vestibular pathology, but you may want to confirm that with a more high frequency test, such as the video head impulse test. And again, what we can see here is that in fact this patient does have a bilateral vestibular loss. And therefore weren't able to detect the asymmetry on the rotary chair test because both vestibular systems were affected, but we can measure the asymmetry properly with the video head impulse test, and we can see that both sides have reduced VOR gain because it's a side-specific test. In summary, hopefully you now have a understanding that the vestibular system responds differently to different stimuli, and the fact that we have different tests which can measure at different frequencies. By doing that, what we can do is we can diagnose disorders of the vestibular system where only certain frequency ranges are affected. Therefore, having access to these tests allows for a more complete assessment to be performed, and you'll be able to identify those patients with a vestibular disorder much more easily. So that brings me to the end of my presentation, and I welcome any questions. As I mentioned before, the presentation will be posted on the Introacoustics Academy website in the next couple of days, and that can be accessed by going to academy.introacoustics.com. Okay, so I don't see that there's any questions. That's absolutely fine. If you do want to send me a question regarding the presentation, then please send an email to lema, L-E-M-A, at introacoustics.com. Alternatively, you can send it to the Academy email address, academy@introacoustics.com, and I'll get those questions answered for you. So thank you very much again, and I look forward to seeing you on the next webinar. Goodbye.